Glad to see everyone still here, and let's get on with the keynote session. Our first talk is by Dr. Randhir Sood on endocytoscopy and future of GI imaging, toy for a few or must for all. Dr. Sood doesn't need any introduction. We're looking forward to the talk, Dr. Sood.
Thank you, Shivangi. I changed the topic a little bit, tweaked it, because I thought the topic was too, broad and not very specific. So I made it endomicroscopy, a toy for a few or must for all. Because the other, image enhancing endoscopic techniques are well established, and we have evidence that they are useful. So I will not take them at all. You know, the endoscopic techniques, can I have a pointer please? Endoscopic techniques have evolved over a period of time, but basically they fall into two groups. One is the wide field endoscopy, where it is either a highly magnified endoscopy techniques where 4K and 8K has come in, and then there is virtual chromo endoscopy. Various companies have got various pre-processing and post-processing techniques, which are many of us are using, and then contrast enhancement techniques, which have stood the this one, okay, so which have stood the over a period of time have served us well, and then the fluorescence endoscopic techniques have been there. But what I'm going to concentrate is in microscopic view, where endomicroscopy comes in, and there are basically two types of these techniques which are available to us today. They are ultra high magnification endoscopy, which actually gives us cellular level information in real time, and that's what we call optical biopsy. And for this, like histopathology, we need either topical staining or intravenous staining with fluorescein. And these two techniques are confocal laser endomicroscopy, which is known as CLE, and endoscope based CLE was initially started by Pentex, but unfortunately it is not commercially available anymore. And probe based technology, which is probe CLE, this is okay. Okay. You want this? Okay. Probe-based technology, which has been aggressively marketed by Salvigio and has been in use for quite some time. I think it was introduced in somewhere in 2005 or 7. And then Olympus introduced endocytoscopy, which was probe-based to begin with during its entire journey, but had become endoscope-based now, and that is what is became commercially available since 2018. This is what Salvigio looks like, which is a probe-based CLE, and that's how the probe can come out of any endoscopy channel which is 2.8 or larger. And there are various probes which are in use today, and the endoscope-based has been discontinued by Pentex, possibly awaiting more refinement. The basic principle is that you try to project a low power laser onto the lesion through a pinhole, and then you give a intravenous fluorescein. Earlier we used to use topical cressyl violet and acryflavin, but all know that acryflavin has some teratogenicity, so it has some mutagenic potential, so it is not being used anymore. So IV fluorescein is used, and when you put in a project the laser onto the lesion, there is a fluorescein scatter which is picked up, and only the central part, the very small area of the lesion is seen through the pinhole, and this magnifies it anything from 600 times to 1000 times. And this technology has been able to enable us to miniaturize to the level that we can put in today a probe, which is a needle probe, through a 19 gauge EUS needle to interrogate cystic lesions of pancreas, or even solid lesions, or even lymph nodes in future. So on the other hand, as I told you, cytoscope today is just like a routine endoscope. It comes as a upper GI endoscope and a lower GI endoscope, standard diameters, and it is just integration of the microscope inside a 290 series Lucera Elite system. Unfortunately not available in India, and I think it's available predominantly in Japan and some parts of Europe. But it has the advantage that it has wide view endoscopy, which is highly magnified, and you can also use its optical biopsy characteristics, which gives it certain advantages, which I'll come to later. That's what endocytoscope does. That you see a lesion on standard endoscopy, the same endoscope, you put in the stain, but this has to use topical stain, which is normally chrysal violet plus methylene blue, or for small bowel, possibly toluidine blue is used, not methylene blue. And then you turn the liver and you put into the zoom, which is 520 times magnification, which gives you a microscopic image of the lesion. Now the area of clinical use are inside the GI lumen for both, that is esophagus, stomach, but CLE, because the probe can go through a double balloon enteroscope or single balloon enteroscope, can interrogate the small bowel up to any length where the scope can go, as well as colon, while the endocytoscope, because of its size and limitation to 2 standard endoscopes, can only interrogate esophagus, stomach, duodenum and colon. The advantage with the CLE probes is that you can go inside the bile duct with a Clongioflex probe, and inside even PD, and you can even interrogate pancreatic cysts and solid tumors outside the lumen by using EUS-FNA 19 gauge needle, through which the needle probe can go. And now they have started interrogating the sentinel lymph nodes, which can actually give us very important information. And of course, there is a separate probe for which goes through the bronchoscope for interrogating lung lesions. Now, before I answer the question whether it has relevance for everybody in clinical practice or is it still investigational, I'll have to look at what is the evidence of efficacy of these techniques. This is the evidence of efficacy in Barrett's neoplasia. Let's start from esophagus down. And there is a meta-analysis, 8 studies, 700 patients, and pooled sensitivity and specificity for Barrett's esophagus and associated neoplasia was nearly 90% sensitivity, but specificity was only 75%. And if you look at per location analysis, then the sensitivity drops down substantially. That means that if you do not localize the area of interest, then you may miss lesions with this technology, because the probe is small and it cannot visualize rest of the lumen. So sampling error is serious limitation, as the biopsy site may not always correspond to the area which you localize to the CLE, because here you are doing CLE and then taking biopsies. So red flagging by either magnification endoscopy or AFI or NBI is essential, so that you can localize the area, then apply the probe to the area specifically to be interrogated, because that is a very narrow field. And this is one study in from a single center which showed that if you apply AFI as the red flag technology and then apply the targeted CLE, and then the sensitivity and specificity increases substantially. However, when you talk of specificity, this is important, because if you see the PV guidelines, unless you have more than 90% specificity in your in your pathology equivalent, you cannot use it as a routine. You still have to have histopathology. So these I'll skip because I don't think we need to go into what are the criteria for diagnosing. Now let's come to squamous cell carcinoma, esophageal squamous cell carcinoma. It has, you see that this is the normal esophagus which looks on CLE probe, and you can see the squamous cell carcinoma, very distinctly distinguishable. There is a total irregular architecture, varying size, nuclei, very dark and neoangiogenesis, and you have capillary leak of the fluorescein into the interstitium, and that gives you diagnosis of a squamous cell carcinoma. But this is a disease which is not so prevalent, and 21 patient study where they were suspected squamous cell carcinoma. Overall accuracy was very high, the specificity and sensitivity were really high, and inter-observer agreement was almost perfect. So it is easy to diagnose esophageal squamous cell carcinoma with the CLE. Now let's see where does the endocytoscopy stand. Unfortunately, there are no clinical studies on Barrett's esophagus or related neoplasia with endocytoscope. Comparison has been made only in the biopsy specimen, resected specimen, and this is done only by the developers, the Innois group, and sensitivity, specificity, and accuracy for esophageal squamous cell carcinoma was in 90s, so very high, but it is not a clinical study. It's on biopsy specimens. And sensitivity and specificity for of EC on non-differentiating non-neoplasia and neoplasia was again high amongst experts, but not so by people who started using it early. So not a very useful tool there too. So let's come to stomach. The sensitivity and specificity of established criteria was almost 90% and 99% for atrophic gastritis, more than 90% in intestinal metaplasia and for gastric cancer, and very high inter-observer agreement. I think this is one area which may see use for this technique. And when you talk of the studies, clinical studies, there are 2 meta-analyses, and again confirming the high sensitivity and specificity for both gastric neoplasia and particularly gastric adenocarcinoma. And real-time PCLE targeted biopsies after FICE was significantly superior to taking biopsies after standard biopsies after FICE. So this looks to be promising. And CLE may be of value in screening for early gastric carcinoma. Flagging techniques needs to interrogate suspicious areas. But when we talk of endocytoscopy, again, large-scale evaluation was done on biopsy specimens, not on clinical studies. And again, the overall sensitivity and specificity was in the realm of 80s, and we still do not know whether clinically this is valid or not. Now, when we talk of small bowel, CLE has been used very interestingly for through the double balloon enteroscope, and a meta-analysis of 3 studies of more than 100 patients has very high sensitivity and specificity in diagnosis of celiac disease. Now, you don't need CLE for diagnosing celiac disease, but this was the study, and comparable for adenoma diagnosis, the magnification endoscopy plus NPI was as good as applying CLE. The more interesting thing was the aspect that in a group of IBS patients, they sprayed certain allergens in the mucosa, and they saw certain functional changes in the duodenal mucosa like epithelial leaks, increased IELs, which happened within 5 seconds of the spray, and in intervillous spaces started widening. And when these patients were put on abstinence from these particular food allergens, they had significant clinical response. So maybe this may have some application, but do you need CLE for treating, knowing the allergens in or food intolerance in IBS patients? The endocytoscopy has only been used in duodenal diseases, very limited data. There was only one prospective study of 40 patients. Again, EC could easily diagnose celiac disease in these patients. And now there are well-established criteria of endocytoscope diagnosis in celiac disease. In colon, this is CLE is impractical for screening and surveillance because you cannot see large areas. So you will still need a flagging technique like a magnification endoscopy or a chromoendoscopy or virtual chromoendoscopy to target the areas. And we don't know whether there is any superiority of using CLE with this. In a meta-analysis of 100 patients on image-enhanced endoscopy, the sensitivity and specificity of virtual chromoendoscopy techniques and CLE was practically the same. Again, we don't find any advantage of applying optical biopsy with CLE in this situation. So the result of CLE in detection and characterization of colorectal neoplasias remains inconclusive and does not support adoption of CLE in screening protocol. The use comes in IBD, where it has been used to diagnose, differentiate Crohn's disease from ulcerative colitis, assess severity of inflammation, predict relapse or therapeutic response, and detect dysplasia or neoplasia. In patients who had macroscopically non-inflamed mucosa on white light endoscopy, the CLE could identify inflammation. And if there was normal CLE findings, this was highly predictive of deep remission. So this seems to be something of use. There is meta-analysis of 15 studies, around 700 patients, for diagnosing colorectal neoplasia and IBD, which was, this was highly sensitive and specific in diagnosis, but we don't know whether this was having any superiority over the regular virtual chromoendoscopy techniques. So CLE imaging in IBD patients to guide optimized therapy and is a completely new area, and it has still not been included in any official guidelines for IBD management, though maybe this may have a application in future. When we talk of endocytoscopy, the evidence is again similar, that there is very little clinical data, mostly bench studies, and accuracy is high, but we don't know how it will apply to clinical scenario. The advantage of endocytoscopy is that you have got a magnified endoscope with you, so you have got a flagging technique available to you. And this is how on endocytoscopy you see adenoma, which has got tortuous crypts and elongated nuclei, and when it comes to a cancer, there is a very easy recognition of adenocarcinoma, which you can see. This is again based on diagnostic criteria which has been established by Inouye's group, and this has a high sensitivity and which is equivalent to the histopathology. In pancreatic diseases, mostly it has been used for the pancreatic cystic lesions. CLE was found to be superior to US CEA. But in clinical practice, you diagnose CLEs, PCLs by clinical history, by cross-sectional imaging, and cyst fluid analysis, and not only by cellular diagnosis. So may not be CLE, may not add value there. In biliary strictures, we have got large data with the cholangioflex scope probe, and there are studies of almost 600 patients, and sensitivity and specificity in indeterminate biliary strictures is very high when you add CLE to CLE plus ERCP biopsies. But there is no study comparing it with cholangioscopic biopsies with CLE. So we don't know whether it has any additional value. Asia Pacific consensus recommendation did say, despite certain limitations, virtual histology based CLE may be complementary. Now let's come to how easy to acquire the skill of doing endocytoscopy or CLE. This can easily be, the differentiation can easily be acquired by looking at the videos and tutorials. But the problem comes in acquiring good images, and there's limited evidence that on learning curve to perform CLE is steep, like understanding the pathology, and it may be difficult to make a diagnosis in real time for the beginner, and it may require significant period of time. So ability to interpret images is not equivalent to ability to generate good quality images. In future, artificial intelligence and computer-aided diagnostics may be able to complement CLE and EC diagnosis, because then acquisition of images is not dependent on the individual operator. And the other is that EC platform has the advantage of integrated magnifying endoscopy and NBI, and this may possibly be more useful in screening and surveillance in colonic and gastric neoplasms. I think the most important function, when you look at what CLE does, we have been comparing only the histology versus the the changes which CLE obtains, and we are comparing pathology. But CLE has the advantage that it looks at that pathology in a live situation. So what advantage it has is in physiology. So apart from GI morphology, the cell function and molecular processes investigation by CLE may or endocytoscopy may be of greater advantage. In fact, there are some very interesting studies like fluorescent tagged adalimumab when was injected in patients of ulcerative colitis. The mucosal TNF immune cells could be detected easily, and patients who had high density of mucosal TNF cells on this had a much higher 12-week response as compared to those with fewer cells. And similarly, targeted peptide-based imaging has been used with different antigens for detecting CA stomach and for diagnosis of Barrett associated neoplasia. Similarly, if you are investigating a sentinel lymph node, if you inject a fluorescein labeled dye into the tumor, you can pick up that dye in the sentinel lymph node, and you can know that there is a lymph nodal spread by interrogating the lymph node with a needle CLE. So, to summarize, the feasibility of use of GI in biliary lumen is well established with one of the endomicroscopic techniques. Potential role in extraluminal cysts and solid tumor and lymph nodes is coming up. Skill in acquiring and interpreting images is possible after formal training, and artificial intelligence and computer-aided diagnostics may be of great help in making the routine endoscopists comfortable with this technique. But while PCLE still has modest data of clinical efficacy, we don't have any data with the endocytoscopy. But endocytoscope has potential for screening and surveillance, and combination with molecular imaging raises exciting possibilities. Now, what's the verdict? Is it a toy, or is it something to have something we all must have? Now, I think with the evidence which I have projected in front of you, I will say that today it is not time mature enough for you to spend money on endocytoscopy or CLE till we have more robust data, because you see the Barrett's esophagus, you don't get any advantage. You see the gastric cancer, possibly some advantage, but is that the disease which we look at? Not at least in India, unless you're practicing in Kashmir or Northeast. Colon, again, it has the same value as virtual chromoendoscopy techniques associated with magnified endoscopy. The only area where I see is studying the cellular cellular processes and molecular tagging, which may be of great help in future. And so, if you like to have a Lamborghini in Delhi streets and drive it there, then you can buy it. But otherwise you can do with your image enhanced endoscopes, which have got virtual chromoendoscopy. Thank you very much.
Thank you, Dr. Sood. We will have question answer sessions at the end of keynote session. The next keynote lecture is by Dr. Mahesh Goenka, AI in Endoscopic Diagnosis, Impact and Future. Everybody knows Dr. Mahesh Goenka. I need not introduce him. So Dr. Mahesh Goenka is available online. Welcome, Dr. Goenka.
Can we have my video? Thanks to everybody, and I'm sorry for not being present physically, but we can run through the video. I'm sorry, but we cannot cut down the time because it's a pre-recorded video. In 15 minutes or so, I'll be talking to you mainly about artificial intelligence in GI endoscopy. I must at the outset tell you that I'm not an expert in artificial intelligence, but I'm interested in the subject. In our daily life, we have been using artificial intelligence, sometimes not recognizing that we are using one. Whether it's a Google map while you're driving or face recognition device while you are browsing through your computer, you're using artificial intelligence. So artificial intelligence is there in smartphones, security and surveillance systems, social media platforms, navigation, e-commerce, and so on. I'll be, however, talking only about artificial intelligence in GI endoscopy. The subject is so important that now there's a journal dedicated to AI in gastroenterology. In my talk, I will include a few definitions and concepts very briefly, use of AI in endoscopy, and share some of our personal data. AI refers to simulation of human intelligence in a machines programmed to think and act like human. It's a broad platform. On a very basic aspect, it is telling the computer or the machine a particular design that will be recognized by the machine later on. But it can be very sophisticated, which include machine learning, deep learning, which can be supervised or unsupervised. And the deep learning may involve convoluted neural network in which the computer has multiple hidden layers so that it decides which parameter to give importance and which to not, so as to reach a final decision. AI in GI endoscopy can include computer-aided detection or AID, computer-aided diagnosis of cataracts, predictive modeling, endoscopic quality assessment, and also assist in reporting. Adenoma detection rate, we all know, is so important. In Western world, in various studies, the rate can be as high as 30 to 40%. But even in our country, polyps are not rare, and a recent report from Hyderabad showed that 10.2% of the colonoscopy had polyp. We must recognize that on an average, each 1% increase in adenoma detection rate can lead to a 3% decrease in the risk of colorectal cancer, and that is huge. We must also understand that while you perform endoscopy, you collect large amount of data. For example, a 15 minutes procedure with 30 frames per second of image capturing can give you 27,000 images. And it is not very difficult for a human brain to miss some of these images, leading to misdiagnosis. Human brain has limitations, both in terms of working hours and is subject to fatigue, mood, and expertise, whereas machines can work for 24 hours without these limiting factors. So the first work on polyp and AI was published almost about 6 years back, when polyp was detected by using energy maps. Ever since, various players in endoscopy field, Fuji, Medtronic, Olympus, and Pentex, have come out with their own artificial intelligence system. There are more which are waiting to be launched in commercial. Medtronic system is called GI Genius, very simple, a box which you attach to any of the machines. And when it finds a polyp, it puts a green colored rectangle around it with a sound. And this can help you in assessing this area more carefully. And in a study from Italy by Repesi, it was shown that adenoma detection rate can increase by use of Medtronic GI Genius from 30% to 44%. This is a huge increase. This is CAD-eye system from Fuji. We have had the experience of using Olympus EndoBrain artificial intelligence, which is again very simple, just push of a button. So it has two components. What is automated polyp detection. So this is a colonoscopy, and there's a small polyp behind a fold, which can be easily missed on the normal colonoscopy. But when you use AI and you reach that area, the AI will give you a sound and will tell you that with a probability of 90%, there's something there, and so you can spend some time looking at that area. EndoBrain has gone a step beyond to characterize the polyp. So this is a polyp in the colon. So you first use NBI and then use endocytoscopy. And then by push of the button, you can know that this is neoplastic with a probability of almost 95% in the different parts of the lesion. You can also stain this polyp. And after staining, you use endocytoscopy, which can not only give you histology, but can also tell you with high probability that this is neoplastic, in this case, almost 99%. Let's look at another video of another polyp, a small flat polyp. So NBI, followed by endocytoscopy. And then you use artificial intelligence, and it shows that it is likely to be non-neoplastic or hyperplastic with a probability of 97%, another area 92%. This polyp is again stained, as you will see. And after staining, You can again use endocytoscopy and artificial intelligence to show the histology, and on push of the button, it says that it is non-neoplastic with a probability of as high as 90 to 95%. So this is what is known as CADX. So there are a number of studies which has looked at CADX result for differentiating adenoma from non-adenoma, and the results are almost consistent with a sensitivity of 92 to 94% and negative predictive value almost reaching 90%. So this is likely to change our paradigm for the polyp management, at least for the small polyp management. From dissect and histology, we may move towards diagnose and leave if they are less than 3-5 millimeter and the artificial intelligence shows them to be non-neoplastic. Beyond polyp, what's the role of artificial intelligence? So it can help us in endoscopic quality. So it can detect whether you've reached the cecum with 98% accuracy, and also give you an idea about bowel preparation with a high degree of accuracy. What are the other areas where it has been used? It has been used in inflammatory bowel disease, and I'll just show you a very short video. So this area of the colon, the artificial intelligence tells us that the disease is active, and in another area, it will tell you that the disease is healed with a probability of as high as 82%. So this is another promising area. The other areas where artificial intelligence has been used is diagnosis of early gastric and esophageal cancer, Helicobacter pylori-like changes, related changes, dysplasia in Barrett's esophagus, and very significantly, it has a use in capsule endoscopy, where it can significantly decrease the reading time to less than 10 minutes from usual of more than an hour. Now, this is a study published a few months back where artificial intelligence has been used in capsule endoscopy for detecting small bowel bleed. As compared to the earlier version, here it is almost 100% accurate to detect blood in the small bowel. As you can see in the various images, it says with certainty whether there is blood or no blood in the capsule. It has also been used at capsule endoscopy for diagnosis of vascular ectasias, ulcers, and polyps. Now, let me, in the next 3 or 4 minutes, share some of our personal work. We have been a part of the machine learning for classification of indeterminate biliary strictures, which we all know are so difficult to diagnose during cholangioscopy. This is a work which was presented last year in American College of Gastroenterology, a multi-central study which involved us and some other centers from India. And we gave our images from both Spyglass DS1 and DS2, which was trained to the machine. And a large set of data was put in. 13,71,000 images were used for initial learning and validation. And in the first result, it shows that very good ROC for differentiating normal from abnormal cholangioscopic findings. So this was 25 centers with large amount of images being used. The other area we have been working for the last few months is role of artificial intelligence guided upper GI endoscopy in assessing the procedure completeness and quality. We all know that for colonoscopy, there are good criteria, ileal intubation, cecal withdrawal time, and so on. But they're not much of a parameters used for upper GI endoscopy. So with the help of a Hong Kong group, this is under publication, we developed 29 areas in the upper GI endoscopy. They can be part of the antrum, fundus, incisura, lower body, mid-upper body, duodenum, esophagus, EG junction, epiglottis, and vocal cord. And I'll just show you how the system works and run through this short video. So as you see the beginning of the endoscopy, you see the epiglottis. The epiglottis is seen here, and a box against the epiglottis is sticked. Then you move forward to look at the vocal cord, and once you are focusing the vocal cord, the image comes here, and the box against the vocal cord is sticked. And so at any stage, you can find out what are the areas which you have examined. So at this stage, only 2 out of the 29 areas have been examined. And this gives you a bird's view of position of the endoscope. So you move on and then go to the other areas. And here we are in the duodenum. And as we are entering the second part of the duodenum, you'll see that once you get a full view of the second part of the duodenum, the image of the second part of the duodenum will come here. And the box of the D2 will be ticked. So you can now make out then the tunnel view of the second part of the duodenum. The image comes and the box is ticked. So at this stage, 10 out of the 29 areas have been observed, and then you move forward, and then you come back in the stomach, do retroflexion to look at the various areas, and at some stage you have reached all 29 areas, and at this stage you can see that all the boxes are ticked, 29 out of 29 areas are seen, and the whole upper GI tract has become green. So the final picture which you get on the computer is something like this. So you have all the 29 images, and it shows that 100% of the examination has been performed. Though these are early days and we are trying to validate it externally, but I find that it's have a promising training tool for upper GI endoscopy. We did a small study in our department where we retrospectively analyzed 277 upper GI endoscopy and divided into those performed by trainees and trainers. And as expected, we found that the trainers covered much larger areas than trainees did. We also found out that some of the areas which are commonly missed were vocal cords, epiglottis, and incisura. And this can be, again, very important take-home messages. So this is two of the final results. In this case, 20 out of 29 were observed, so 68% success. And in this case, all 29 areas were seen, so 100% success. The other areas where we have worked with other people in India and outside is to develop and validate a post-ERCP pancreatitis risk factor and machine learning-based decision-making tool for prophylaxis selection. So what we did is 12 multi-center randomized controlled trial evaluating post-ERCP pancreatitis where evaluated. A gradient boosted machine model was used. This included 7,000 plus ERCP with a PEP rate of 8.6%. We evaluated 22 possible post-ERCP pancreatitis risk factors and 4 possible prophylactic interventions, rectal NSAID, hydration, combination, or stenting. And we found out by using this module as to which are the variables which are important with decreasing importance, BMI, age, guide wire in the pancreatic duct injection, minor papillae sphincterotomy, and so on. And we developed an ROC curve, which was quite robust. And based on this, we produced a medical calculator called post-ERCP pancreatitis risk calculator, where just like any other medical calculator, you put age, sex, BMI, and the other risk factors, and it gives you an approximate predicted risk of post-ERCP pancreatitis. And also tells you that if you use these prophylactic measures, how the risk of pancreatitis can be reduced. Again, this requires more validation, but appears very promising. We in our department, a couple of months back, started GI Genius study where 300 consecutive patients were enrolled in the age group of 15 plus. And we had 2 groups, one without AI and one with AI GI Genius. This is an interim analysis of 265 patients. So in the first group with AI, we had 20.7% had polyps, where those without AI, 13.3% had polyps. So there was a difference of almost about 8%. And this difference was more marked as expected for smaller polypi. Now we all know from this network meta-analysis that artificial intelligence is the most important factor to increase the ADR rate and is better than most of the other devices which have been used. But can we improve our results by using a combination? So we have started another study in our department in which we have 3 arms. In one we are using endocuff. Endocuff, as you know, is a device which you put on the distal end of the colonoscope, and these flanges will flatten the scope folds while you are withdrawing the scope, and thereby visualizing the other side of the folds. So in one of the arms, we have AI with endocuff, and the other 2 arms are only AI or only endocuff. And we will try to find out whether we can increase the results of artificial intelligence by using endocuff. Now, what's the future of AI? Future looks bright. This is a new device, not yet commercially available, where the polyp can be characterized with 3 levels: non-neoplastic, adenoma, as well as invasive cancer. And so by looking at the mucosa and using endocytoscopy and artificial intelligence, you can even say whether the cancer which you are seeing is invasive or not. So this is, again, very, very interesting. Now, let me now end with a couple of slides. Now, so what is the potential impact of artificial intelligence in medicine? I will refer to this study from Martin McCurry from Johns Hopkins, who in 2018 published his data that in USA, the commonest cause of death was heart disease, followed by cancer. The third commonest cause of death was medical errors to the tune of 2.5 lakhs in a year. And maybe by use of artificial intelligence, we can decrease these medical errors and the death related to medical errors. Now, what are the limitations of artificial intelligence? Single center learning in most of the studies, so we need external validation, which I talked about. We still don't have gold standard for some of the parameters. There's issues related to cost and legality. But artificial intelligence is here to stay, so it's always good to shake hands with this new technology. Thank you very much.
Thank you, Dr. Mahesh Goenka. Please remain online till we finish all the keynote lectures. It's a pleasure to call Amit Maideo for the next keynote lecture, and he's going to talk on the ever-expanding scope of GI endosurgery. Dr. Amit Maideo.
चल रहा है नहीं not coming I'll have to give my lecture tomorrow. Okay. Huh? Not coming. Yeah. Okay, so thanks once again. And so I'm going to talk to you now on this very, very interesting topic. That is the expanding scope of GI endosurgery. And I think Amol gave me this topic because I'm a surgeon who converted to endoscopy 35 years back. And if you see the evolution of GI endoscopy, from diagnostic endoscopy to interventional endoscopy to therapeutic endoscopy to what we are likely to face now, that is flexible endoscopic surgery, except for the first era, 1950s to 1960s, I think it is somewhere around mid-1980s that I entered this field. So for last 35 years or so, I have actually witnessed this entire metamorphosis of the field of GI endoscopy. And I'll just tell you what is its present state. If you ask me personally, the true father of GI endosurgery or flexible endoscopic surgery is Professor Nip Sohendra. Because 35 years back when I joined his department at the University Hospital of Hamburg in Germany, his department was called Department of Endoscopic Surgery, UKA, Hamburg. I never imagined, and I'm sure even he never imagined, that the field of GI endoscopy is going to get transformed so much in the next few years. Unfortunately, before these procedures like third space endoscopy got launched, Professor Sohendra retired. But till then, a lot of progress was done. And if you see here, when I was in his department in the 1986 till 1990s, that time I witnessed what was actually therapeutic endoscopy. Nip Sohendra never called it interventional endoscopy. He told me this is therapeutic endoscopy and slowly converting to endoscopic surgery. So procedures like variceal sclerotherapy, cyanoacrylate glue injection, PEG, gastrostomy, esophageal dilatation with bougies, esophageal plastic stent placement, of course biliary sphincterotomies, stone extraction, plastic stenting, were all routinely performed even 35 years back. And I know that the mother-baby endoscopy was already introduced, and we could even crush stones, difficult stones from the bile duct, even in patients of Mirizi syndrome. And you see here procedures like endoscopic ampulectomy, polypectomy, even flat polyps. He started doing it 35 years back. So already there was a beginning of endoscopic surgery. You see here, this is one of the videos which I took from NIPS Sohendra so many years back, where in a patient of Barrett's esophagus, without using any cap, without any submucosal injection, directly with a monofilament snare, he just resected that mucosa completely. And you see, this was the aggression, and this was the true beginning of endoscopic surgery. What happened is, in the mid-1990s till mid-2000, there was a sudden explosion of technology. What came was high resolution, high magnification endoscopes, enhanced imaging machines, self-expanding metal stents, hydrophilic glide wires, steerable catheters, dilatation balloons, various dissection and resection knives, suturing equipment, stapling devices, hemoclip and closure clips or devices, and even defect closure devices. And then what happened is, somewhere from mid-2000 till 2022 was what I call the true era of growth of interventional endoscopy, and therapeutic endoscopy started changing into endoscopic surgery. You see here, ERCP was not only restricted to simple CBD stones, but we could treat even very difficult CBD stones or hard radio-opaque pancreatic stones, and even treat patients of Mirizi syndrome. People started resecting early cancers by EMR, ESD, FTR, treating patients of GERD with ARMS, ARMA, full thickness plication, TIF or MACE procedures. Third space endoscopy caused a tremendous revolution. Various procedures I showed you before. Bariatric endoscopy was being practiced. You see here, endoscopic sleeve gastroplasty, pose procedure or the TOR procedure, edge. Some people, some endoscopists also started slowly replacing traditional surgical procedures like treatment of appendicitis by going in with a colonoscope, placing stents in the appendix and doing treatment for acute appendicitis. They did a transcecal appendicectomy procedure by resecting from the appendix opening, going outside in the peritoneum and taking the appendix out of the colon. Then of course, resection of low rectal cancers, along with lymphadenectomy by going inside the peritoneum. Cholecystitis also started being treated by a few physicians from the world. I'll not name them just now. Some on swine, some on pigs, but some even on humans. And there were some endoscopists who have even attempted a gallbladder preserving cholecystolithotomy, saying that it is not required to remove the gallbladder. So by going inside the peritoneum, opening the GB, taking out the stones and then leaving the patient alone. Then of course, flexible endoscopic mediastinoscopy with lymphadenectomy and even treatment of colonic cancers. So look at this. This was the tremendous growth which was taking place. And you see here, various types of procedures were now being practiced for so many years. You see here, ESD, POEM, STIR, GPOEM, ZPOEM, etc. And in addition to that, you see here, endotherapy of GERD, ARMS, ARMA, full thickness plication, etc. And in addition to that, bariatric endoscopy, I told you, just a few glimpses. Endoscopic sleeve gastroplasty, as you can see here. By suturing devices, we could close or make the lumen of the stomach smaller, or you could do transoral outlet reduction in a patient who has undergone a bariatric surgery in the past, and in a patient who had undergone a Roux-en-Y bypass, who developed CBD stones. By US guidance, you could make a puncture into the excluded stomach and then put a lambs, go inside that with a ERCP scope and remove those stones by ERCP. Look at the amount of intervention which was being done. Well, suturing devices created a completely different revolution, and you see here, even after doing a full thickness resection in the duodenum, or even if we did a full thickness resection in the esophagus, we could easily close these defects by using suturing devices. You see here, on the left side, we are using a suturing device to close a duodenal defect. On the right side, we are suturing a esophageal defect. And of course, as I told you, there were some endoscopists who started breaking all traditional barriers. Just to show you a few videos, flexible endoscopic transcecal appendicectomy. By putting a colonoscope inside the cecum, you see here they are dissecting outside, just outside this small tumorous area which is there at the appendicular orifice, make a cut, go in the peritoneum, and finally this appendix was taken out completely and this opening was closed again by loop and a clip method. Or for example, oh my God, once again this is hanged. Something wrong. I was almost coming to the end of my talk. Sorry for this. Same thing again. But is it going to work now? Let's see. I think there are too many programs going on. Okay. Are you getting? Got it? Okay, last few slides. But I have to show you because this is very, very interesting. And here you can see now again a gallbladder preserving transrectal cholecystolithotomy. So anterior wall of the rectum, submucosal tunnel, going outside the rectum, entering with a flexible scope in the peritoneum, going towards the gallbladder, opening the gallbladder and taking out the stones and closing the gallbladder by using clips, simple hemoclips. So this was being practiced by a few endoscopists. Again, not in clinical use, but they did it on a few patients and it was being used. And you see here, some also attempted a non-stenting transgastric gastrojejunostomy. So not by doing a US guided LAMS, but under US guidance, puncturing the jejunal loop through the stomach and around the guide wire, dissecting, going out of the stomach, going along the wire, going towards the jejunum, opening the jejunum, then after opening, caught hold of the edge of the jejunum, pulled it in the stomach and attached it to the stomach opening with clips. And with this, they did achieve a result in those few patients which they attempted. But I personally feel that this is taking things a little bit too far. Because you see here, the same endoscopist from China also attempted esophageal tumor resection with mediastinal lymphadenectomy in a pig and a EFTR of a colonic tumor with lymphadenectomy, that is mesorectal lymphadenectomy, and he attempted to do that procedure. So what happened is, over the last 35 years of this so-called growth of interventional endoscopy to therapeutic endoscopy to endoscopic surgery, endoscopists really started feeling, and I have a feeling they still got a feeling, that they are going to replace surgery. But I'll tell you, this surgeon who you can see who is hanging in the cupboard is not just hanging, but he is smiling. Because the surgeon and even surgeons of today, they know that irrespective of whatever types of interventional endoscopy we do, we are never going to be able to truly replace surgical procedures, except for a few examples like achalasia cardia or maybe for CBD stones. But the true surgical procedures which are carried out in the peritoneum, in the mediastinum or in the thorax, it's not going to be easy. Now, why is it like that? Because this transition from flexible GI endoscopy to flexible endoscopic surgery requires a different mentality, a different technique, and a different technology. Now, what do I mean by different mentality? Whenever a doctor chooses to become a gastroenterologist or a surgeon, we have to understand that person has got certain inherent qualities and some inherent likings because of which he chooses that particular specialty. For example, the main qualities of an internist or a gastroenterologist are a person who thinks carefully before acting, deep intellectual curiosity, interested in mental stimulation, more receptive to emotions, and a vivid power of imagination. What does a surgeon have? The surgeon's qualities are an ability to adapt at a moment's notice. He likes to see concrete results at every step. For example, at every step you take, you have to see a new result. You can't keep on scraping the surface. You have to go one step ahead. Third is a stamina to sustain long procedures, quickly adapt to unexpected situations, and always pragmatic. So if a gastroenterologist wants to become a flexible endoscopic surgeon, he has to start thinking like a surgeon. And if a surgeon wants to become a GI endosurgeon, he should adapt and develop the qualities of a gastroenterologist. So it has to be a blend of both. It cannot be one or two, because otherwise you will not be able to achieve this. Second important thing is the technique. The two basic principles of surgical technique, whether it is open or it is minimal access, is optimize exposure and permit triangulation. What is the meaning of triangulation? Is you should be able to lift and cut, lift and dissect. Traction and counter traction is extremely important. Today we saw so many interventional procedures, ESD being performed. What was the main issue? The main issue is proper exposure and the ability to achieve traction and counter traction. As you see here, the present limitations which we have with the normal endoscopes and accessories is, we have a lack of the multitasking endoscope. There is a limitation in the number and size of access channels in the endoscope, inability to position, stabilize and fix instruments, and inability to retract and expose, and very, very important, inability to triangulate. And unless we develop the ability to triangulate, we will never be able to achieve the true endosurgery. So the ideal platform for GI endosurgery should be ergonomic but flexible. It should provide stability at the tip, multiple large instrument channels, and the end instrument should have the capacity of triangulation, high resolution imaging at the same time. There should be ancillary ports for CO2 insufflation, irrigation and suction, and a full set of articulated flexible surgical instruments coming out through the tip of a flexible scope. So now what? How are you going to achieve that? So certain industry partners already started developing such type of platforms. And you see here the initial platforms which were developed. One was from Karl Stoss, second was from Boston Scientific, third was from Olympus. The Karl Stoss platform was called Anubis scope. The BSC was called as the direct drive scope, DDES scope. Olympus was called Endosamurai. However, none of these platforms stood the test of time because we could not achieve a proper triangulation and a stability at the tip. So they were never ever introduced into clinical practice. Along with that, special scopes were also introduced, like the shape lock transport endoscope you see here, or the Cobra triangulating endoscope, and the R scope from Olympus, which had multiple bending areas. But with these multiple wheels also, in spite of multiple bending, we couldn't achieve a proper stability. The limitation of the existing endosurgery platforms is that the additional angulation at the tip reduces the stability. There is no tactile feedback when the endoscopist is trying to do the procedure, and as the instrument becomes more complicated, it hinders your procedure rather than helps you. And a single operator is extremely difficult to control so many buttons. Now when you are performing so many multiple tasks, see, a surgeon has got help. There are many other people holding the trocars, various other ports. A single endoscopist trying to do with everything with one instrument is not going to be simple, and with every additional function It is going to reduce the robustness of the platform, the stability, and the practicality. Well, we were exposed to one of the most latest platforms which was going to provide probably an answer of endosurgery. You see here, and on this platform, which was a multi-armed robotic endoscope, we performed work on humans for almost 1 year. And you see here, inside the lumen with this platform, you could actually hold it from one side, dissect it, and actually take a suture. And here you can see here, we are actually using it on a patient. And here you can see the endoscopic picture. This scope is being driven. This is just the outer sheath. The endoscope is actually attached over here. And this entire sheath was moving in and out only by press of certain pedals. So the endoscopist is sitting at a different location by using the various buttons, and with a foot pedal, with fingers, with hands, you could actually drive this. But after use of this platform for 1 year, we realized that still it has got a very, very long way to go because of the flexibility, the ability, the stability, the tactile feeling. Nothing was there in this platform. It was looking beautiful. The main issue is, by doing all these procedures, we could produce beautiful videos, we could circulate them on WhatsApp groups, receive lot of likes on Facebook. But let me tell you, these type of videos and these type of procedures where we are going to try to replace surgical procedures are not going to be so easy. So finally, what I want to tell you is that there is going to be a scope for us to improve, because the human mind keeps on thinking, industry is also thinking. So I'm reminded of the words of this Nobel laureate, Robert Long. You see here, who won the Nobel Peace Prize. He's a physician who said that only those who see the invisible can do the impossible. Even though we are trying to do that, but at this stage, and probably for the next 10 to 15 years, I don't think that we will be able to really replace the advancement in minimal access surgery by entering the peritoneum or by entering the mediastinum. We have almost reached the end of the road. Thank you for your attention.
Thank you, Dr. Maide, for that excellent talk. Last but not the least, it is my honor and privilege to introduce our next keynote speaker, Master Endoscopist, Dr. Nageshwar Reddy, who will be talking on cognitive training and skills assessment for GI endosurgery.
In this very important workshop. In fact, every year Amol has been doing a fantastic job in this very specialized area. I would have very much liked to be there, but unfortunately, because of my commitment and another conference, International GI Workshop at Athens, I can't be here during this period. However, I'm going to talk on cognitive training and skill assessment in GI endoscopy, which I believe is becoming increasingly important. In 1970s, the pioneers in GI endoscopy actually were self-taught men. You can recognize most of them who actually brought in many new procedures, but none of them received any training. They were actually very brave and they were real pioneers. In 1980s, training endoscopy became more formalized, and you can see the technique of endoscopy used to be one of a master apprenticeship one, a mentor having a mentee and is training him one-to-one. This is also now changing because of rapidly changing procedures in GI endoscopy. There are advanced procedures which are becoming more and more common, unlike standard procedures which are taught at the basic fellowship program. These, of course, advanced endoscopy programs require a different type of training and different type of assessment, and this is what I'm going to concentrate on, the sub-specialization of GI endoscopy and how to train these endoscopists. In fact, third space endoscopy is a huge spectrum starting from esophagus, stomach, rectum, and I think many of you who are there here this evening are all experts in this area. But we require to train more of our youngsters to do these procedures. So what I'm going to do basically is to try and answer these 4 questions. Why should we train our future gastroenterologists in this procedure? Whom should we train? How should we train? And finally, very important, how do we assess that we have trained them adequately? Of course, India is a huge population, 1.4 billion now. So there's definitely increased needs for more centers which have to train for third space. For example, we are now rapidly shifting from pancreatico-biliary endoscopy to third space endoscopy. In fact, paradoxically, most of the third space endoscopy procedures are relatively easy, but we require to have new pathways for youngsters so that future developments can occur. So as subspecialization in endoscopy increases, there's a need to train more and more youngsters in this new pathways so that they have a future direction. In fact, when third space endoscopy started in India, it was just a few centers, and now you can see there are I think more than 100 centers doing third space endoscopy, centers doing large volumes of poems, and so on. So we come to the next question, who should be trained? I think this is fairly easy to answer, that for advanced endoscopy training, it should be those who have completed the fellowship, or surgical endoscopists who are again interested or devoted to endoscopy. And again, it's preferable that people who are trained are those in the younger age group, say 35 years, or at least definitely below 45 years. I think for the older generation, learning new procedures is not only not so easy, but you can concentrate on a very certain specific procedures, but not on a whole gamut of new advanced endoscopic procedures. But more important than who should be trained is who shouldn't be trained, because several of us in the bigger institutions actually get requests for training in endoscopy. We have very casual endoscopists who want to do 4 or 5 cases of poem and try and go and see what he can do. Especially single practitioners who are non-institutional, who have lack of infrastructure, should not be, you should not put our effort into training them, because ultimately this training is lost. They won't be able to continue their procedures. In general, there are 2 types of endoscopies, thinkers and doers, and they are exemplified by this example of Pankaj and Harrow. Pankaj was a thinker, and thinkers are the ones who are very good at diagnostic endoscopy, at sort of finding out what these lesions are in terms of enhanced imaging. And doers are the ones who go and do and dissect out these lesions. So I think it's very important to clearly identify whom you're training, whether it is a thinker or a doer, before putting your efforts into training this person. So when we come to this other important aspect is how should we train our individuals or those who are going into advanced therapeutic endoscopy. Many of us in the older generation were actually trained or inspired by congresses like this. We'd go to a big congress, usually the Hong Kong conference at that time, see what's happening, and then try and come and duplicate these procedures, just read and watch and perform like they say, watch one, do one, and so on. But this is no longer tenable, especially for advanced endoscopy procedure. We have to have a more structured program. And I think in this very nice article by Mihir, who is there, and his co-authors, they very clearly showed that in new technologies in advanced endoscopy, it's very important to go in a stepwise manner. That is, you first receive cognitive training and of course technical skill acquisition. This is usually done either by looking at images or working on models. And then the second step is you train under direct supervision. And the third step is by performing procedures independently. Now, these 3 steps are very, very important in advanced endoscopic training, and ESGE now has put specific numbers. For example, they have a cognitive technical skill training, which to do with at least 20 models, then training under supervision to be done at least under 5 cases, and finally performing independent procedures at least 20 before you are declared that you are competent in that particular procedure. So I think this is becoming increasingly important, because it's important to remember that no procedure is a make or break event for trainee, but it is for the patient. So especially when you are embarking on training them on dangerous procedures, it has to be in a very structured way, using a variety of techniques. So what are these techniques that are available to us? Mechanical simulators are there, but unfortunately they are not useful for third space endoscopy or endoscopic surgery. There are biosimulators which are the most commonly used ones. As you can see that following this workshop, I think Amol has arranged a very nice hands-on training. Computer simulators are coming, but they're not yet there. I think the most commonly used models are these inflated porcine stomachs or inflated bovine colon. Unfortunately, they can't duplicate real life situation. The only way to duplicate real life situation is to do it in live animals. But I think there's a lot of problems. In fact, in our own hospital, we have a live animal lab, but there's so many ethical considerations, so many other considerations that has to be taken, the cost factors, I think the logistics and so on. And therefore, to a large extent, although they're ideal for third space or endoscopic surgery training, live animals are not commonly used. What about virtual simulators? Again, virtual simulators are okay for basic training, endoscopy, colonoscopy and all. Up to now, they have not been up to mark when training for more advanced procedures like third space procedures. There are a lot of people working in this area, and hopefully in a few years' time, we'll get virtual simulators and they may become the primary and starting point of training. What we also require to have is good endoscopy training centers, and again, like Amul has organized there, we have also the AAG Endoscopy Training Center with 7 stations, which is fully equipped, and this is where we find we can give the best possible training to our trainees, because they are in an optimum atmosphere, they have everything that's available, and of course, it is done in a very conducive manner. This is important. Because for optimal endoscopic training, you require not only an appropriate training environment, modern equipment, so you require a lot of support from the industry, which helpfully is coming in. Of course, culture to ensure sufficient opportunity, very motivated trainees, high quality trainers and robust assessment. Of course, you have to also have examples set up in our own units where we can train, show the trainees what should be the setup when they go back to their particular center, so that they know how the setups are, and this is very important for them to align with. But more important than all this, and I've learned this from my experience in being the World Endoscopy Organization Train the Trainers program, we actually did this program all over the world, where we went around training people in different aspects of advanced endoscopy. And what we found was that there are several types of trainers. There are ones who are not competent and who don't know that they're not competent. There are ones who are incompetent, but they also know that they're incompetent. But the most common trainers are those who are competent. They can do the procedure well, but unfortunately they can't explain the procedure. This is called unconscious competence, and these are the majority. What we ideally require is this group of people, conscious competent. That is, they are competent, they also know they're competent, and they can very effectively deconstruct a procedure and explain this to the trainee. Like Aristotle famously said that those who know do and those that understand teach. So the most important large aspect with Amol asked me to talk about is how do we assess our trainees in advanced endoscopic training. In general, historically, the assessment has been done in terms of numbers. That is, you do 200 ERCPs, you're supposed to be trained well. You do 30, 40 poems, you're supposed to be trained well. But there's a lot of inter-operator variability, heterogeneity among the trainees and trainers, and therefore competence in endoscopy assessment is not so easy. We have to look at other things, not only numbers, but we have to look at for example, R0 resection rates when you're doing complex ESDs. You have to look at complications that have been potentially produced, both potential complications in a model or complication that occurs when you are being trained under observation. All this has to be, these key performance indicators are very important, and many of these are being developed for different types of procedures. And some of these assessments, I just show you examples of recent literature. This was stepwise training in rectal and colonic submucosal dissection with differentiated curve. For example, these are all experienced endoscopists actually, an Italian-Japanese study, which showed that after you reach 5 cases for rectal ESD and about a similar number for colonic ESD, your time taken for resecting a centimeter or unblock resection changes. So it's about 5 for a very experienced endoscopist. Again, this is a study which actually put actual numbers to what learning curves should be. For example, for comfortable ESD detection for esophagus, it's 170, 150 for stomach, colorectal. Now, these are large numbers, and unless you're in tertiary centers, these numbers are difficult to obtain. Again, even for EMR, this very interesting study showed that to reach a competence level where you can do with low proportion of residual polyps and do a complete EMR, you require an average about 100 or 120 cases. Again, very large numbers. For POEM, it's much smaller. You reach your expertise by 40 cases. You become a super expert probably by 60 cases because of inherent nature of this procedure itself. So these numbers are now sort of fixed, but what is very important is to do in a structured manner, as ESG has shown us. That is, you deconstruct each procedure, for example, ESD into different things, and set targets for this. For example, the core skills are defined by characterization of the lesion and so on. Quality metrics are defined upon R0 resection, and you set targets at 90% en bloc resection, 75% curative resection, less than 3% of perforation before you declare somebody as competent. And of course, you validate some tools which can be very easily validated, which can be put. I think this is a very important guide for us, how to train people in advanced endoscopy, how to deconstruct, give importance to each area, and how this can be validated. Like very famously, Aristotle said that we are what we repeatedly do. Excellence is not an act but a habit. So you are not born as an excellent endoscopist. Of course, some people have better hand-eye coordination. They learn quicker, and that's why you have so much of operator differences between different individuals. But what is very important to realize is that everybody can be trained properly in these procedures, and we have to set a definite, and not only numbers wise, but also a definite key parameters, key performance indicators which suggest that this patient is competent. And the ESG deconstruction of how this can be done is very important, and for all the trainers, I would suggest that they study this pattern so that can be implemented. And finally, I'd like to sort of conclude by saying that training endoscopy is to train doctors and not technicians. We make this mistake of not looking at the patient fully and train our doctors to do these procedures as doctors and not technicians, because as Peter Cotton famously says, it's important to look at the patient as a whole and not just the hole in the patient. Again, Amol, thank you very much for giving me this opportunity to participate in this very important conference. With the permission of the chair, I'd like to invite you all to Endocon 2022, which is on 8 to 10 September in Hyderabad. We're going to have over 20 international faculty, over 250 national faculties, over 50 live cases, and of course over 70 debates, talks, lectures, and controversies. I think this is going to be one of the largest endoscopy live meetings this year in our country, and looking forward to seeing you at Hyderabad.
With this, we come to the end of the day's session. It was a very hectic and busy day today, and I would like to invite you all. Before that, I would like to thank all the speakers and the chairpersons for their contribution. Thank you very much. Please join us for cocktails and dinner in the hall adjacent. Thank you.